Okay, well, thank you very much, Radha. And I'd like to thank the SPOI and also Florence from SOS Oxygen for sponsoring my attendance at this meeting. I know that you all must be bored and maybe tired from the long travels. At the same time, I also acknowledge that everyone who's here is quite knowledgeable about respiratory diseases and its epidemiology. So what I decided to do is change tack a bit and give you a case study in South Africa about respiratory diseases, because I firmly believe that as respiratory physicians and collectively as respiratory societies, we have a responsibility to advocate for better respiratory health in the world and in the regions that we represent. Now why is this not changing? So respiratory health in South Africa, I subtitled my talk Impending Respiratory Failure. And I hope at the end of the talk you'll understand the various dynamics that we face in our country that impact negatively on the respiratory health status of our population. Now why is this? It's not changing here. No, it's not. Oh. Okay. So let's go to the next slide, okay? Right, so South Africa has a population of 56.5 million and growing. In fact, in 2016, we added close to 1 million people. And I think if you look at the population growth the world over, there's no question that we're going to experience a population explosion in the world in relation to the limited resources. You have to understand that the planet is a finite planet. It's not going to grow in size. In fact, its resources are diminishing relative to the population. And over time, we're going to get major civil unrest in many regions in the world due to lack of space, overcrowding, and in relation to that, you're going to see an explosion in respiratory diseases. So my view is that unless we as respiratory societies advocate for better respiratory health, I think our doomsday predictions are going to come true. So what do I mean by that? I think the most important thing that we need to look at is that the single most preventable respiratory cause of respiratory disease in the world is cigarette smoking. There is not a single government in the entire world, and again we've lost all hope in the United States, that is prepared to ban the growth of tobacco and the production of tobacco-related products, which is killing the people. There is nothing that you can ever find about tobacco that is positive. Even the income that they get from the taxation on tobacco products is spurious, because the cost of health care of tobacco-related diseases far exceeds the tax returns that governments get. So South Africa is going to, like the rest of the world, show a growth in population. Now it's a bit difficult to follow two sets of slides, but what I want to show you here is, this is the problem we face in South Africa. Now the reason I'm using South Africa, and that's my country, as a case study, is when we achieved our democracy in 1994, there was this euphoria that South Africa is going to be the country in the third world that is going to show the world how it's going to develop. But tragically, because of institutional misgovernance, corruption that characterizes many developing countries, what you see is a worsening in poverty. And this slide very clearly shows that when you look at poverty by head count and by age, and each of those lines represents a different year. And what I want to point out to you is that from 2006 to 2011, there has not been a dramatic drop in the poverty indices in our population. Now when you look at what are the threats to lung health in South Africa, firstly it's tuberculosis. Now I think for those of you who know tuberculosis epidemiology will readily acknowledge that South Africa is amongst the top 3 high-burden TB countries in the world, and I'm going to discuss that in greater detail in my presentation on tuberculosis and HIV in South Africa. So without question, relative to its size, South Africa is a leading country in terms of tuberculosis incidence and related tuberculosis mortality. And that includes XDR and MDR the tuberculosis. Now when you look at HIV, again South Africa is a winner because to date it produces the largest number of new cases of HIV infection. And the tragedy of that statistic is the greatest number of infections occurs in young people. That means particularly females between the ages of 12 and 34. Which means that we're producing yet another generation of HIV infected people. Now there is this, again, this euphoria that if we get everyone access to antiretroviral treatment, then we will cure the problem. But what we are doing is we are producing more cases that need treatment, and as of now, and I'll illustrate to you towards the end of my talk, it's actually bankrupting our healthcare system. And relative to its financial situation in 1994, South Africa has shrunk considerably to the extent where the international finance houses such as Moody's and Smith & Poor's had last week downgraded South Africa to junk status, which has tragic consequences for its healthcare. Then you look at smoking. Again, we carry a high burden of smoking which is no different to developing countries. And in fact, what's happened in South Africa, and Fan Chang, you need to listen to this carefully, is that the Chinese have moved into South Africa and they brought with them cheap cigarettes. So people can smoke at lower cost, but cheap cigarettes bring more respiratory diseases. So we are seeing this big market of cigarettes being marketed not only in South Africa but in developing countries. And to date, governments do not have the wherewithal and the conviction to tackle this problem head on. Biomass fuel, again, South Africa like a developing country, and given the poverty indices that we face in our country, more and more people are becoming poverty stricken. The gap between the rich and the poor is actually widening, and South Africa has been recorded as having one of the worst gaps in wealth index in the world. So the proportion of rich are getting richer and the poor are getting poorer. And the poor, in order to survive, have to then survive by accessing very poor quality energy sources, which is then causing more respiratory disease. Occupational and environmental health. Now South Africa, like any other developing country, is industrializing rapidly. Now when you do not have good governance, industries would prosper at the expense of the poor people who are required to work under poor conditions. Whilst we have an excellent human rights charter, we have one of the best healthcare policies in the world in terms of control of the work environment, but we have one of the poorest records of implementation of the standards in the work environment. So you're going to see more and more people suffering from industrial diseases. Poverty, I already indicated that, and then infections, HIV, tuberculosis, and respiratory infections that I will illustrate to you. And then asthma, I'll show you some statistics shortly. So what I want to show you very quickly, I don't need you to read everything on the slide. South Africa recently published its data on the South African Demographic Health Survey. And basically, it interviewed about 11,000 households and basically gave us a picture of the current status of health in South Africa. And I'm just going to give you excerpts from that survey. So you can see when you look at the people who smoke in the Demographic Health Survey in 2016 versus 1998, you can see we've made some inroads, but there's a non-significant drop in the proportion of people who are smoking. And there's no doubt that that's going to impact negatively on respiratory health in relation to the other problems. So what I mean by that is cigarette smoking increases your risk to get tuberculosis. Cigarette smoking increases your risk to acquire HIV infection. Cigarette smoking is a well-established risk factor for getting pneumonia and more severe pneumonia. Now when you look at the interplay of all these factors in our environment, you can understand why we're going to face such a huge burden of respiratory diseases in our country. Now, respiratory health and respiratory function in adulthood has its origins in early childhood. There's no question about that. In fact, from embryonic time right through to early childhood would determine your ultimate vital capacity, for example, which then determines your respiratory health as an adult. Now, when you look at the nutritional status of children by age in the Demographic Health Survey, you can see about 30% of children are stunted by age. And that is a serious problem for respiratory health. Now, if these same children are then exposed to industrial pollution, environmental pollution, HIV and tuberculosis, you can understand why we're going to see a major explosion in respiratory diseases, okay? What about drinking? Now, the reason I'm putting alcohol here, because alcohol, again, is a risk factor for tuberculosis. I think in the early days there was a study that was published from the UK and subsequently confirmed by the study in Tucson, Arizona, that people who drink have a higher prevalence of chronic bronchitis. I think, Fan, you'll know that it's referred to as whiskey bronchitis. And somehow that seems to have been lost in current epidemiology, and I don't know the reason for that. But certainly in the Western Cape region of South Africa, we see one of the highest prevalences of incidences rates of tuberculosis in the world ever recorded, 2,000 per 100,000. And one of the reasons for this is not HIV, but actually a high prevalence of poverty and alcohol consumption. And again, you can see that from a very young age to old age, alcohol consumption is actually quite high. Now, the CAGE test is a test of how people who are interviewed perceive themselves when they drink, whether the social functioning, how they feel about the alcoholism, and you can see it's a serious problem. What about obesity? Now, the reason we have to factor obesity into whatever we discuss is because obesity is going to represent in developing countries the second wave of epidemics of diseases that we're going to encounter, the diseases of lifestyle. What has that got to do with respiratory health? Everything. So you're going to see a surge in obstructive sleep apnea. We cannot afford have the resources to treat people. We're going to see a surge in diabetes. Diabetes is a risk factor for tuberculosis, pneumonia, and other diseases. So that's going to impact negatively on respiratory health. So you can see how we are in a bind in our country when you look at the various factors that determine respiratory health. Now, what about behavior? So our HIV incidence, I said, is highest at the moment amongst young women. And in fact, if you didn't believe me, here's the statistic from the South African Demographic Health Survey. If you look at the percentage of women between the ages of 15 to 19 who've had a live birth, you can see that overall between 3.8 to 28% of these young women are actually falling pregnant. Now, can you understand in your mind what that means? Almost all of these are single women, unmarried, mostly almost all at school, who are falling pregnant and then have to bring up children. And you can see not only the problem they have for their own well-being, but for their children's well, they're going to grow up in this society. And in fact, society has this feeling that every child must be looked after, but if you do not provide long-term for these children, they're going to be victims of all the diseases that we know impact negatively on respiratory health. And it's a serious problem we face. Now, what about causes of death? So if you look at the causes of death in South Africa between 2013 and 2015, so it is infectious and parasitic diseases, diseases of the circulatory system. I want to concentrate on respiratory diseases, which ranks number 5 as important cause of respiratory diseases in South Africa. Okay, but if you look at it by death, by gender, you can see that amongst males, tuberculosis ranks as the topmost cause of death in South Africa during the period studied. In females, it is third most common cause, surpassed by diabetes and cerebrovascular diseases. So you can see how tuberculosis impacts negatively in our country. Now, you heard the statistic from India about asthma, and asthma and COPD are the two important diseases we concentrate on in our deliberations. Now, South Africa, according to the Global Asthma Report in 2014, was ranked as a country having the highest mortality from asthma compared to all the other countries in the world, including our good neighbor Zimbabwe. But the problem here, I would always cynically observe, is that half of Zimbabwe's population is actually currently in South Africa. And the latest statistics is that South Africans are running away from South Africa to Zimbabwe since Mugabe has retired. But the problem is that it's tragic that South Africa has the highest mortality, and despite the fact that there may be misclassification in the statistic, I think even if you have that, I think we have an a very seriously high, unacceptable asthma mortality. And you need to understand that this is against a backdrop of the only country in Africa that has access to inhaled corticosteroids at all primary healthcare clinics. So clearly we are not doing something right. Okay. So again, this is just looking at that slide of the top 10 leading causes of death. So it's tuberculosis, diabetes, cerebrovascular diseases, influenza and pneumonia, okay, also ranks up there, okay. What about childhood mortality? Again, if you know, a country must be judged by how well it performs, by the health of how well it looks after its mother, its women and children. And we have a very high childhood mortality rate, and it hasn't changed dramatically from 1998 to 2016, which again shows the problems that we are facing. We also have, I forgot to put the slide up, one of the highest maternal mortality rates in the world. Okay, obviously it's related to HIV, tuberculosis and everything else, but clearly it's a problem. And like I said, if we judge a country by how well it treats its women and children, then South Africa is doing extremely poorly. Right, what about biomass fuel and indoor pollution? So we can extrapolate information from the type of fuels that we use. So this is a study that looked at indoor fuel use between 1998, 2003 and 2007. And you can see still a high proportion of people using paraffin, wood and coal for energy source in their homes. And again, it relates to poverty. Okay. Now if you look at the risk of acute lower respiratory tract infection, the odds ratio of developing it in relation to polluting fuels that I described, you can see that clearly there's between a 4 to 6 times increased risk of getting acute lower respiratory tract infections amongst children due to exposure to these polluting fuels. Okay, I just put the slide up so that you can see. This is a summary from the South African Demographic Health Survey that the South African Medical Research Council put out as the key indicators of findings from that. In South Africa, apart from this high burden of HIV, tuberculosis, we also have violence as an extremely common cause of death. If you look at drug addiction, cocaine abuse is 23 per 1,000 women and 15 per 100 for 1,000 men. So you can see we have a serious problem in South Africa. Okay. Now if you look at how are we equipped to deal with, let's say we can't do nothing about the respiratory diseases that we are producing, how well do we deal with it? Now you can see that in South Africa, how many pulmonologists do we have? Now in KwaZulu-Natal, which is the province I come from, the population there is about 12 million people, the most populous province in the country. How many pulmonologists do you think we have in KwaZulu-Natal? 15, 1-5. How many bronchoscopy centers we have in the state sector, noting that 80% of the population of KwaZulu-Natal seek health care in the state sector. How many bronchoscopy centers do you think we have? We have 2. One in Durban and one in Pietermaritzburg, which is 80 kilometers northwest of Durban. So we are not even geared up to meet the challenges. So unless we do something about the factors that is promoting respiratory diseases, we are going to be in for a serious disaster. Okay. Now, if you look at indoor pollutions, the reduction in pollution that would occur if you electrified it, you can see that you would, just by providing electricity, this slide shows that you would get dramatic reductions in indoor pollution. And I mean, there is a huge drive in South Africa for electrification of the homes, but this project is marred by high levels of corruption, which I'll describe to you just now. Okay, so the patient-doctor ratio in South Africa, apart from pulmonologists, we have 25 per 100,000 doctors in the public sector. We have 92 per 100,000 in the private sector. Okay, and in the international norm is 150. The average in South Africa is 60 if you combine the private and public sector patients. In India it's 70, in Brazil it's 189, and in China it's 194. So clearly we are in the bottom of the ladder again when it comes to the doctor to patient ratio. Now if, as the WHO proposes, every individual should visit his general or primary care physician at least 3 times a year. If we did that, immediately South Africa would be short of 1,400 doctors, which we cannot meet. Okay. Then if you look at the other side of the statistic, and let's say we are producing graduates to feed the healthcare system, 70 to 80% of graduates are not happy to work in the state sector. They either go in the private sector or they emigrate. And there must be a good reason for that, because these are youngsters who can see the world and do not see South Africa and certainly the state sector as an appealing career option for them. So we're investing in them, but we're losing them because we cannot retain them. So let me give you some harsh statistics about South Africa and the current news. Now in KwaZulu-Natal, we have only one center in the state that treats oncology patients. You heard about the high level of lung cancer in India. Relative to our population, ours is even higher. Nobody has a clue how high it is, because basically everybody who comes into the state sector with an abnormal chest X-ray gets treated for tuberculosis, because we do not have the resources to investigate them. Only those who come in with gross presentations, who are easily diagnosed, would get diagnosed. Now if they get to an oncology center, are they going to get treatment? In KwaZulu-Natal, with a population of 12 million people, with the highest prevalence, incidence of tuberculosis, HIV, and other respiratory diseases in the country, we have an oncology center that has collapsed. And if you don't believe me, this is an article published just today, or yesterday, sorry. Okay, so, and the Director General for Health of KwaZulu-Natal has been suspended because of this. There's not a single oncologist in the state sector that is able to treat patients. And patients are dying. And what's happened in South Africa is patients are now suing the Department of Health for negligence. And the bill in KwaZulu-Natal alone is 2 billion rand that they have to pay in medical legal costs. Now you calculate that, okay? In Gauteng, now Gauteng is the richest province in South Africa. Johannesburg is its capital, and it houses the mining houses, so it's extremely wealthy. Its Department of Health is bankrupt. It has to call in for a group to come in and rescue it, okay? Now what about reorganizing or retooling our healthcare system in the state sector? So our very brilliant National Minister of Health has proposed a national health insurance scheme, very much like the NHS. All the economists have told them that this is not going to work, you do not have the resources. South Africa's economy is shrinking. Our growth rate is 0.5%. We've been reduced to junk status. Despite this, the Minister of Health is quite adamant that he is going to continue with providing the national health insurance. There is no money to do it. In the face of his persistence, the hospitals in the South African public sector are actually degenerating. King Edward Hospital in Durban, which used to have a bed count of over 2,000 beds, one of the second busiest hospital in South Africa and the second busiest hospital in Africa, is now in a state of total disintegration. After the recent floods we had, there is not a single theater that is operational. So we are facing a serious, unmitigated disaster in South Africa. And despite this, our brilliant Minister of Health wants to persevere with setting up this national health insurance, for which there is no funds. So you can understand how we are just going backwards, okay? Now what about the Western Cape? Western Cape is a very well-organized province run by the Democratic Alliance, which is a political party that has its head screwed on right. It runs one of the best healthcare system, and even, unfortunately, even nature is against us, because they are experiencing a drought, and in fact, if the drought persists to the extent that it is, the hospitals will not be able to manage the patients because they're running out of water to provide a clean environment. So you can see that apart from ourselves being our own enemy, even the gods are angry with us. Now, what else? I don't know if those of you who study the economics of South Africa, there's been recently an expose that a particular family from India, unfortunately the Indian delegates walked out, I wanted them to hear this, who moved into South Africa and set up business. And they went into bed with our President Jacob Zuma and basically, systematically captured all the state enterprises. To date, it is estimated that 70 billion rand, which is equivalent to about, I would say, about 8 billion euros has left the country, most of it sitting in Dubai, in the UK, in the US. And in fact, Bell Pottinger, which is a UK advertising agency, was promoting the image of these companies, actually had to shut down in the UK when this expose happened. So I am not giving you false or fake news. KPMG, do you all know KPMG? Accounting company, international accounting company, is being investigated for fraud for partnering with this Gupta family that partnered with our president to fleece our country of its resources. And what resources? The mining sector, the energy sector, the water sector has been eroded by these people. And currently there's a huge inquiry going on in Parliament, and we as citizens are hoping that they would have a investigation and all the people involved in this mega corruption would be brought to book, which means that the government would actually effectively collapse. And that's what we're facing. So I don't know, I mean, you can Google this if you think I am giving you false news. Okay, so we are in serious trouble, okay? So, now the South African Thoracic Society, I believe, like the SPOI and all other society, the European Respiratory Society, the American Thoracic Society, etc., have important roles to play in their regions to advocate for good respiratory health. Each of us has our manifesto of what we should be doing and how we should do it. And the South African Thoracic Society, like the SPOI, should provide leadership, which we try to do under difficult circumstances. We set standards for the subspecialty. We engage with our regulatory bodies such as our Health Professions Council, our Medicines Regulatory Body, and the Department of Health. The problem is there is major institutional misgovernance. So I'll give you an example. The Health Professions Council of South Africa, for example, doesn't know who is being registered when. They mess up your annual registrations. They cannot efficiently register new doctors. At the moment, there are about 30% of our interns who cannot be placed in jobs, yet there is a major shortage of doctors in the country. The Medicines Control Council fails to timeously register a drug. If the pharmaceutical industry is here, they will understand when they apply for a new drug that will improve the patient's quality of life to be registered in South Africa, it takes up to 2 years for it to be registered. Why? Because of the incompetence of the Medicines Control Council. They have a backlog of 5 years. So we have a serious problem, okay? So as a society, we have engaged with them. In fact, when as the president of the society, I've threatened to take them to court because they failed to register 3 respiratory drugs. The one is a combination long-acting beta-2 agonist and anticholinergic, and pirfenidone and the OFEV for pulmonary fibrosis, which are often diseases which patients are prepared to pay for, but they refuse to register it. 2 years it's lying in their desk to be processed for registration. So those are the problems we face as a society, but we hope that by engaging with them we can make a small difference, okay? So I'm not going to go through that or that. So I'd like to end up with this slide. We need ECMO, okay? So like I said, there's impending respiratory failure in South Africa in the setting, and in fact, if you look at it, it's a very bleak picture, and I think certainly if we all put our shoulder to the wheel, we'll probably be able to make a difference. We're hoping next month is the annual conference of the ruling party. We hope that the corrupt ministers would be voted out of their positions, and we'd see the dawn of a new era in South Africa. But I hope that I've been able to make a case study of the problems that a developing country like South Africa, which had an amazing future when Nelson Mandela became its president, can be compromised by institutional misgovernance. And we all need to keep an eye on it and keep our governments accountable. So on that note, I'd like to stop, and I'm happy to take any questions if they are at this late hour, and certainly I'll do a presentation on tuberculosis and we can discuss it further if you want. Thank you. Done.
Have you any questions?
according to the tobacco consumption, have you the BD too?
So I didn't hear that.
Have you BD like in India?
Have I been?
BD smoking.
What's that? BD. No, but South Africa produces the best cannabis in the world. So if you want it, it's there. Particularly Durban, where I come from, we don't have BD, but we have enough smoking. We don't need BD. I didn't. Dr. Menon didn't tell you about reverse smoking that they do in India, but I think we'll get there. You know what's reverse smoking? They light the BD. The women light the BD and put it the other way around in their mouth, so then they get a high incidence of oral cancers. Somehow I think men like to kiss them like that.
D'autres questions? So, thank you very much, Professor Lalloo. It was a pleasure to... Thank you. Donc,